Mm-hmm. Do we need Mike for the questions, or should I just keep? Does anybody have any questions? Yes, in the back.
This is more of a comment than a question. What you did here showed us is extremely useful
Thank you.
in looking at an individual situation. But I think a more realistic type of situation would have been in today's medical practice is we're going to take 8 to 10 hours to see 30 works of art and take 15 minutes each to discuss it.
Yes.
And you're going to be interrupted
Mm-hmm.
several times with some other works
Right.
of art while you're
Right.
looking at it.
Yep.
I mean,
Yep.
you made a mention on
Yes.
time,
Yes.
effect, on all this, but I think that the reality of today's practice makes it very challenging
Absolutely.
in
Yes.
facing the uncertainty as we look
Yes.
at it.
So your question is speaking to, your comment is speaking to the reality of working in a very high volume situation with a lot of interruptions. And how do we, what we're experiencing in art viewing of this like lovely openness and wondering and thinking through ideas is maybe out of touch with reality or pie in the sky compared to what people are dealing with. And I absolutely agree with you that we're working, you're working in a system that is treating complex challenges as if they're going to be able to be solved in a linear way, which they're not. They're complex challenges. And also a lot of interruptions and time pressure. And so what do you do? That really is the dilemma. And, part of, and I'm aware of that. As I mentioned, I really hate telling busy people to slow down, for example. It actually pains me to do that. And so part of what I'm interested as I move forward with my work is working closely on the more organizational and leadership level of how do we cultivate the spaces for this kind of work, which is actually what caregivers want to do and what patients want as well. So I think, so I recognize that totally. At the same time, I think there's a value for remembering and actually having an authentic, real-life experience together with how far we can go and how much we can do with our capacities of language and attention when we really bring it, that needs some kind of place for people to stay in touch with it and forge it back to the clinical practice and sort of valuing these tools that we have so that maybe we can't use them every single time in every single encounter, but in the right, when the antenna goes, wait a minute, I sensed something wrong, like maybe there will be an extra pause or I'm going to hang on a second and, bring in some fresh eyes and ask somebody else, or this patient is making me feel, uncertain in some kind of way, and I'm going to take a pause to, reflect on that and acknowledge that. So I hope that speaks to your point, but I really am I think it's a really difficult moment in our history to be providing care. It's like a time of resilience, and I hope that, I'm very grateful for the work everybody is doing and want them to have all the support they can get and see this work as sort of connected to some of the ideals that we need to stay connected to right now. Yes?
The slides make a number of references to careful language.
Yes.
Could you elaborate on that?
I would love to elaborate on that. So there's a lot in careful language. It's like being able to trust into our language as a tool for sharing our picture as well as facilitating our thinking, and it is just enormous. But and actually in the interactive session later today, if anybody can come, we're going to dig in a lot more to language, and we're going to do more around think aloud techniques. What I was going to talk about today in the the presentation had to do with the way in which the words we choose, whether or not we're conscious of it, they reflect our thinking and our beliefs. And we convey, our words carry so much power. And the wording around, especially around the representation of a problem, or that's used at handovers. There's a growing body of literature studying these actual framing terminology, and the way in which they will impact the subsequent person's thinking, curiosity level, interest level in that patient, as well as like desire to even get involved in the diagnosis. And so the point is that there's some work done by Dr. Arabella Simpkin, who's at the Mass General Hospital in Boston, around language use at handovers and the way in which uncertainty or bias is conveyed. And her, as well as her team, they found that the use of like bringing in really hypothesizing language in the framing is extremely effective in terms of getting the subsequent caregivers, like inviting them into like recreating, wanting to create the diagnosis or the representation of the problem. And that it impacts how people are treated. You can think about, there's also a lot of stigma. Stigma has the potential to be carried over or not in that handover language as well. So it's some of those issues that I'm speaking to. And when we are looking at art in this way, one of the things we're doing is breaking our observations from our inferencing. We're using this forcing strategy. What do I see that makes me say that? To cultivate a discipline. It doesn't take a lot of extra time. It's discipline, which is in itself sort of what drives, art and the art of medicine, or like the craft of providing care. It's these little micro moves of, describing, do we describe somebody as an alcoholic or a retired engineer? It's these little micro moves of, the patient looks normal versus the patient's body is positioned in this certain way, which makes me believe the patient is normal. It's these micro things that make a huge difference. And actually that second example came from a study similar to ours in the Harvard study. This one was done at Robert Wood Johnson Medical School, where they did a visual thinking strategies intervention. And they had, in the pre and the post-test, they had students writing in response to medical images, and they analyzed the writing. And in the pre-test, with regards to the same image, and that literally came out of one of their assessments. The patient looks normal in the pre-test to the same student, same image, describing how the body is positioning, and therefore I think this patient is normal. That's going to make a big difference in how that patient, moves through. So that's the careful language part. Yeah. Yes.
That phrase,
what do you see that makes you say that? Yeah, forcing strategies. Yeah.
And whether that's being asked to you or whether you're asking it of yourself as
right.
that information.
Exactly.
Tell you what I see that makes me say that.
Yes. Right. And that comes into think alouds, which is like when we share, all the best diagnostic safety people, they're just like, one of their uniform messages is share your reasoning, share your reasoning, share your reasoning. And, rather than sort of perform, here's what I think it is, think aloud through the problem in this way that brings others into your thinking, gives you the flexibility to kind of change your mind and try something on rather than like be ready to die on the sword for your argument. Is kind of part and parcel to the kind of psychological safety or the spaces in which people can kind of think and learn together, as opposed to, a more punitive kind of environment where that can't happen so easily. So think alouds, again, this is just like micro move, but that's something that you can do that is, that can be transformative and can also facilitate your own thinking as well. Yes.
When I first saw the title of your talk, I thought right away of percentages, because well, on a large scale, your
Mhm.
symptoms have a 30% chance of being
Right.
this or that
Right.
grade or whatever.
Right. Right.
And you didn't mention that kind of
Yes.
uncertainty at all.
Prognostic uncertainty.
Uh-huh.
Yeah. So that is really interesting, and so and actually the study that I mentioned about Arabella Simpkin's study that she did with Gordy Schiff and Mark Johnson, what they did was very elegant. They had one case that they described in which there was uncertainty, and they described that uncertainty in 3 different ways as a way to do their research. And one of the ways was in percentages. One of the ways was just using this like hypothesizing language. It could be this or it could be that, but we're not really sure. But we're going to continue to try to find out. And then the third way, I actually forget. I'm sorry to say, I'm going to have to get that for you. But what they found was like unless the percentages is like pretty drastic, that it makes people don't really know what you're talking about. And it is, I mean, prognostic uncertainty is itself its own can of worms, and it's really interesting. And one of the things that's challenging about it is like most of the time the prognosis is like actually not really knowable, and sometimes patients really want a prognosis, and sometimes they really don't. And it varies from person to person and family to family based on how they want to live their life. And so it requires a lot of situational kind of discernment to figure out. But it's often not even disclosed at all because most physicians just like, they don't know and they don't want to be wrong. So they avoid it. And that's what's challenging about it. So I don't have like a clear, direct, silver bullet answer to your question. Except to say that, I think these things just need to be addressed like honestly and carefully, and when you really don't know, that just needs to be, acknowledged. And what matters to patients more is like the commitment to be with them and work with them on where they want to go. Yeah. Yes.
You touched on this a little bit, but I'm really thinking, and we're talking a lot about resiliency
Yeah.
for team members and my staff.
Yes.
And I wonder if there have been any studies or
Mhm.
examples of taking this pause, using this approach to
Yeah.
uncertainty that have sustained people more
Yes.
to do this for the long
So
haul.
what you're talking about is something I would really love to do, actually. And I'm at the early stages. I'm running for the first time a Looking with Uncertainty course at Brandeis University. And so I'm just at the beginning I'm doing just a basic assessment now, but what you're talking about is something I would love to eventually research. I mean, there is research. There's a big relationship between tolerance of uncertainty and resiliency. And having comfort, being able to live your life and acknowledge uncertainty and sort of still be comfortable and live your life and create your own story. And so I think there is a relationship there, but I mean, for me, that it all just kind of comes down to confidence, and confidence being, to me, what that means is actually being very well calibrated in your perception of risk. So not bringing in, sometimes we perceive risk and we go towards fear, and that's a good thing because the situation's really risky and we have to be very careful. So it's not to say we should have no fear and just, hold hands and talk about uncertainty. It's really, but what the name of the game is like being very calibrated. There's this great slide that I don't have right now, but it's Dr. Paul Hahn's work, his taxonomy of uncertainty, and it's like, it's our response to uncertainty, and it's sort of like perception is here, and then the various responses that we can have to uncertainty. And it's just when that perception is really calibrated with reality, that's true confidence. When it's not being overly influenced by fear or other emotions.
we often respond to comfort with uncertainty in our patients
Mhm.
as if it indicates that they're not very sophisticated.
Can you say more about that?
So a patient says, I'm just going to live life every day with my New York Heart Association class 3 heart failure
Okay.
as best I can, and I don't really want to think about what might or might not happen 3 or 4 months in the future because I'm fully engaged with my day-to-day experience. So thanks, doc, but I'm comfortable with living this day-to-day, and I don't want to do your advanced care planning.
Got it. Okay.
So we rarely respond to that with, how lovely that your comfort with uncertainty is so much better developed
Yeah.
than mine. We respond to it with, what do you mean? I'm a grown-up with a graduate degree and an internal locus of control. You must be a socioeconomic and intellectually deprived piece of flotsam on the surface of the universe. Because I am a planner, and I'm here to help you plan, and you're telling me you don't want to plan. And I wonder if there's a way to help clinicians come to terms with not only their own uncertainty, but come to terms with where the patient stands on uncertainty.
Yeah. Are you getting at like the extent to which the patient is informed of their decision, or?
There are patients who love to receive all the information and still don't want to plan.
Yeah. Yeah. So what do you do? So that's kind of like an ethical dilemma in which you stand.
I don't have an ethical dilemma. I want to stop them from being judged by my hospital and made to feel bad and have an aversive reaction to the medical setting.
I see.
I'm comfortable with their uncertainty.
Yeah.
I need to resolve that with not letting them have bad things happen, iatrogenic things happen to them. But I can do that. I get paid a lot of money to do that. So I'm okay with that. What I'm tired of is the whole medical village treating that section of people as if they're dumber than the people who want to plan.
Okay. That sounds, so what do others think of that, or is that's sort of more, I don't know if I can answer that, but it sounds
that's
interesting and important.
That is a very poignant concern, because how do we have, how do we accommodate different approaches to decision making? And it may be derived from my personality, and I'm a day-to-day person, and what comes may come, or it could be cultural, right? My culture is present oriented, and so whatever happens in the moment, we'll deal with it in the moment.
My grammar doesn't have a subjunctive. I'm from Laos, where there's no subjunctive, so we don't talk about all this crap that didn't happen.
Right. Or I'm a planner and I need to get all my ducks in a row. Or to put it back on the clinician, there's one of the cases we use a lot in our teaching is decision maker was refusing an anticipated C-section consent. But in the moment, there wasn't a perception by the decision maker that the C-section was necessary. When the fetal monitor started to show signs of distress, the obstetrician went in, it's fine, okay,
Absolutely, right. But everybody's sphincters got really tight in the half an hour between the time that the obstetrician was worried and the time the patient got worried,
Yeah.
And I would just sort of postulate that as we take an approach where we're listening more than telling, it might help a little with that kind of interaction. And I say that because I spend a lot of time in my work is with frail elders, with medically complex people, with a lot of cognitive impairment, and that's who my team is dealing with. I'm an administrator. But you can't necessarily get all the answers in response to be able to have a full understanding of who they are as a person and what they want. So you have to just listen and take those other signs in that you're talking about in terms of just careful observation. So,
Yeah.
And the flip side to that is when we don't have a clear diagnosis for our patients.
Yeah.
And they can't cope with the uncertainty, like, retirement.
When they want, right. Yeah. Right.
And so or
Mhm.
whatever, like how we as clinicians can help our
Your
patients
patience
to
in
cope with
uncertainty.
uncertainty
Yeah.
or understand
Yeah.
uncertainty or take a pause in their desire for
Absolutely.
life.
Yeah.
So what's wrong with me?
Yeah.
Why is my mental status altered when we don't
Yeah.
have a
Yeah. I mean, it's
clear
so
answer?
hard, and that should be like the complementary class, to this is helping our patients in uncertainty, their uncertainty. Um, you know, there's I think it comes back to that, like acknowledging that it's really hard, that we're going to stick with it. There's, sometimes there are, you can find smaller certainties within the uncertainty and express commitment for the long haul. I'm not sure right now, but I'm going to stay with you, and we're gonna keep going and find this out. And what was the last one? Yeah, I mean, I think acknowledging the emotion and the pain of it, and sharing in that to the extent that you can. And there was one other thing. Oh, yeah, and then finding not a false resolution, but some resolution that can be found for today, but still acknowledging the uncertainty. Yeah, but it's really hard. It's awful. I mean, there's no sugarcoating that. Yes.
Thinking there might be another piece there too
Yeah.
of us disconnecting our sense of failure at not knowing
Mhm.
from
Mhm. Mhm.
our discomfort with the patient's
Mhm.
uncertainty.
Right. Yeah. Yeah. Yeah, and at the end of the day, it's up to the patient what they want to do about that, what they're going to do with their life in uncertainty. And
Spiritual care can be a big help in that.
Product
yeah.
placement.
Yes.
What I have a comment. What struck me earlier on even was the similarity between the medical context that we're discussing here and the police forensic
Yes.
context. Policemen,
Yeah.
detectives, and
Yeah.
the greater their confidence is.
Yeah.
We got the guy here.
Yeah. Yeah.
More errors are made.
Yeah.
And they stop looking elsewhere.
Yeah. There's a huge relationship between our visual system and our snap judgments. And we know, like it's even in our language, what we see, seeing is believing. And we know from studies of eyewitnessing that they're so often wrong. And like all these horrendous cases of police brutality, of bad decisions made in a snap judgment moment, like when fears get the better of actually color what we see. And so, if you scratch the surface of the neuroscience of seeing and vision, it's basically inseparable from our thinking and our judgment. So, yeah, I think there's an overlap there with like that work and its significance. And I think there's like this kind of goes back to like there's a lot of really interesting stuff between art and medicine, but there's this really unique opportunity when we start to get into what we see and what we think, where we can kind of really work our judgments. And actually in the afternoon session we'll get some more into that as well. Yes.
Kind of an observation. It seems in art, the piece stands alone,
Mm-hmm.
whereas with people, the piece doesn't actually stand alone. There's a background.
Yeah.
In
Yeah.
the past, when
Right.
physicians actually, and any clinician actually went to the home, and we're actually getting back to that
Mhm.
model with
Mhm.
complex cases.
Yeah.
Where there's a team-based approach and there's home visiting and that kind of thing. In public health, there's home visiting for women that are having babies and for the support they need and that kind of thing. And that's an evidence-based model now.
Mhm.
It's ironic, but so the person doesn't actually stand alone, but yet the system is designed so that it's convenient to the medical system, where the person actually
Right.
has to stand alone in
Right.
they have to go
Right.
to the aura
Mhm.
or whatever
Mhm.
we are
Mhm.
here, and it's fascinating that maybe we need to kind of rethink about how we structure how
Yeah, so you're pointing out that, like, sort of pedagogically, there are interesting similarities between a patient case and a work of art, but one really important difference is that a work of art is it's sort of its own separate thing, its object, removed from time and space and culture and the structure of our society and families, whereas patients are bio, psychosocial, spiritual human beings, very enmeshed with their environments and their families, and we can't. It's a disservice and a moral failure and a failure, a diagnostic failure, many kinds of failures, to see them as separate from that. And
It calls for
yeah.
being a little bit more humble, I guess.
Absolutely. Yeah. 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 And I think so I totally agree with you. And I think what I would do with that pedagogically is, like, we looked at one work of art today. I would love to show you examples of, like, a wide range of works of art, and ranging in all kinds of topics that they raise and dilemmas that they raise and issues that they speak to, or simplicity or variation in complexity level. But one of the things I might do in relationship to that is choose works of art that are particularly complex or speak to our complexity and our intertwinement and the way in which our environments shape our health so drastically, as a way to recognize that. But I agree with you totally. Yeah. And it's very interesting, like, there are really interesting similarities between a work of art and a patient case, and some really unique differences, and that's like what it's all about for me. So, point well taken. Thank you. Any other questions or comments? Yes.
A careful language issue. And
Careful.
Maybe this isn't important, but the definition that you used for uncertainty was a subjective perception of ignorance.
Yeah.
And I wonder if it's more apt to say the experience of ignorance.
Yeah. Yeah. I think it. Yeah. A perception is an experience. Yeah.
Perception almost implies that the ignorance may or may not be there, which is true.
Yeah. Yeah.
But it also doesn't embrace.
Yeah.
The
It's a state.
experience.
Yeah. It's an experience.
And
Yep.
it also seems to me that what you're calling for is for us to embrace uncertainty and to make that our active stance. And then when the obvious things fall away, what we're left with is a practice, the core of which is managing uncertainty.
Yeah. Yeah, I appreciate that very much. I think what I'm trying to say is that we may not recognize uncertainty as often as it's there, and that or talk about it with I mean, you might talk about it. I don't know. I'm like a newcomer to your site here, but that it's one way we can approach the art of and the discipline of providing care is like being in this complex challenge of uncertainty. And that it's in moments of uncertainty where it's very stressful and it's very challenging, and it can also be an opportunity to really open our eyes and to look again for ourselves, to look with our patients, to look with our colleagues, and to learn and move towards creation and learning, and to kind of knowing that conditions are very challenging, but to sort of put out the invitation to do that. And that all these elements are a part of the how you can do that, with tiny changes in your language, or tiny pauses, or bringing in somebody else to look. That these micro moves of looking with uncertainty can shape our approach overall. Thank you.
Please join me. It's 9:30.
Thank you so much. Thank you. Thank you all.